You know that feeling, right? That panic when you're sprinting for a bus or maybe just climbing a few flights of stairs and you just can't catch your breath. We've all been there. But what if that feeling didn't go away? In this explainer, we're going to demystify what's really going on and break down the three main reasons why breathing can turn into a constant struggle. All right, so here's our game plan. We're going to start with what I call the big three problems. Then we'll get into problem number 1, obstructed airways. Problem 2, restricted lungs. And number 3, clogged blood flow. After that, we'll look at how doctors actually figure out which is which, and finally, what the path to managing these conditions looks like. Let's get into it.
So yeah, think about that feeling, being truly out of breath. It's more than just being tired, isn't it? It's a really fundamental signal your body is sending you. And for millions of people, that signal is basically on a constant loop. So let's figure out what's causing it.
Okay, so when we talk about lung disease, it can feel overwhelming. There are so many different names and conditions. But here's the secret. We can simplify it. Doctors have a framework for this, and it boils almost everything down to just 3 main types of problems. And understanding this framework, well, that's the key to the whole thing.
And this is where it gets really interesting. It all comes down to a super simple but critical distinction. You've got 2 main buckets. In one, you have obstructive diseases. That's the can't get air out problem. In the other, you have restrictive diseases, the can't get air in problem. So, are you trapping air or can you not get enough in? Let's tackle that first one, the can't get air out problem. So, problem number 1, obstructed airways. And I want you to hold on to this analogy because it's perfect. The narrow straw problem. Just imagine it for a second. Trying to breathe out forcefully through one of those little coffee stirrers. Getting air in might be okay, but pushing it back out, that's a huge struggle. That's obstruction.
Right. So the official medical term here is, you guessed it, obstructive disease. The main issue, the real heart of the problem, is that you can't get the air out effectively. And what happens then? Well, that old, stale air gets trapped. It just sits there. 2 of the absolute classic examples of this are asthma and COPD.
And if you want to see this in action, look no further than an asthma attack. It's like a perfect storm, a cascade of events. First, you get exposed to a trigger. Could be anything, right? Pollen, smoke, whatever. That kicks off step 2. Inflammation. The inside of your airways start to swell up. Then, step 3. The muscles around those airways clamp down, they constrict. And to top it all off, step 4. Your body pumps out a ton of extra mucus that clogs everything up. All of that together, that's your narrow straw. And it makes breathing out incredibly difficult.
Now, let's talk about COPD, or chronic obstructive pulmonary disease. With COPD, that narrow straw problem isn't a temporary thing like an occasional asthma attack. It's a constant and it gets worse over time. The one word you need to remember for COPD is right here, air trapping. The lungs just stay, well, they stay overinflated because you can never fully push all that old air out.
And this isn't just an invisible problem. That chronic air trapping literally changes a person's body over time. You can see the signs. You might get what's called a barrel chest, where the rib cage actually expands to hold all that trapped air. People will often lean forward in what's called the tripod position, hands on their knees, because it helps them use other muscles to breathe. And you'll see this thing called pursed-lipped breathing. It's almost like they're whistling on the exhale. It's a really smart subconscious trick the body does to create a little back pressure to keep those airways from collapsing.
Okay, so we've got the narrow straw problem down. But what if your airways are wide open? What if there's no obstruction at all, and you still can't breathe? Well, that brings us to problem number 2, restricted lungs. And we've got another great analogy for this one, the stiff balloon problem.
Yeah, just take a second and really picture that. Trying to inflate a stiff, old balloon. That quote just says it all, doesn't it? The effort you have to put in is huge. But the balloon, your lungs, it won't stretch. It won't expand. The problem here isn't a blockage. It's the lung tissue itself. It's lost its flexibility. So with the restrictive disease, we're talking about disorders where the lung tissue itself becomes stiff and scarred. The medical term is fibrosis. And that stiffness just physically stops the lungs from filling up all the way when you breathe in. So the key hallmark here isn't air trapping like before. It's a reduced lung capacity. You just can't get as much air in. And a really serious example of this is a condition called idiopathic pulmonary fibrosis, or IPF.
And Well, a disease like IPF is incredibly serious. This number on the screen, it's pretty sobering. 2.5 to 3.5 years. That's the median survival time after someone gets diagnosed. The scarring just keeps getting worse, it's relentless, and that's why, for many, a lung transplant becomes the only real long-term option.
Okay, so we have blocked airways, can't get air out. We have stiff lungs, can't get air in. But there is a third, totally different reason you might not be able to breathe. What if your airways are clear and your lungs are perfectly flexible, but it still feels like you're suffocating? Well, then the problem might not be with the air at all. It might be with the plumbing, the blood flow.
And this is probably the best, most direct way to understand it. A pulmonary embolism is essentially the same concept as a stroke. It's just happening in the lungs. Instead of a clot blocking blood flow to the brain, it's blocking blood flow in the lungs.
So, what exactly is a pulmonary embolism, or a PE? It's a blockage in one of the arteries in your lungs. But what's so important to get here is that the problem usually doesn't even start in the lungs. Most of the time, a blood clot forms somewhere else, often deep in the veins of the leg. That's called a DVT. Then, a piece of that clot can break off, travel all the way up through your heart, and get stuck in the lungs. And that creates an instant and often very dangerous blockage.
So what puts you at risk for these kinds of clots? Well, you can see a lot of them are pretty common situations. Things like being immobile for a long time. Think after a major surgery, or even just on a long flight. A history of clots is a big one. Smoking, obesity, certain hormone therapies. All of these things can increase your risk. It's basically anything that lets blood sit around and pool in your legs, giving it a chance to clot.
So there we have it. 3 totally different problems. An outflow problem, an inflow problem, and a plumbing problem. The big question is, how does a doctor figure out which one it is? Well, they have a whole diagnostic toolkit they use to play detective and find the right clues.
And it really is about using the right tool for the right job. For example, they'll use something called PFTs, or pulmonary function tests, breathing tests. Those are perfect for measuring airflow and telling the difference between an obstructive and a restrictive problem. A simple chest X-ray can look at the lung structures and rule out things like pneumonia. But if they suspect a plumbing problem, like a PE, they need something much more powerful. That's where a spiral CT scan comes in. It gives them a 3D map of the blood vessels. And they might use a blood test called a D-dimer to help rule out a clot. See? Each test looks for something very specific.
Okay, so once the diagnosis is nailed down, once they know which of the 3 problems it is, the path forward, the path to management, becomes so much clearer. The goal is always the same: target the specific issue to make breathing easier and improve that person's quality of life.
And the strategies naturally are completely tailored to the problem. If it's an obstructive issue, the goal is to open up those airways, so you use things like bronchodilators. If it's a restrictive problem, you want to try and reduce that inflammation and slow down the scarring, maybe with corticosteroids. And if it's the plumbing, a clogged blood flow issue, the goal is to bust up that clot with fibrinolytics and then prevent new ones from forming using anticoagulants, blood thinners. The treatment has to match the problem.
So at the end of the day, your lungs are sending you signals all the time. And now you know the 3 big things they might be trying to tell you. Is it a narrow straw problem, a stiff balloon problem, or a plumbing problem? Persistent shortness of breath is one of the most powerful signals your body can send. So the final question is, are you listening?